president of Indore Society. And then she was part of the governing council of ICOG, past president of Indore Menopause Society. She became member of ISAR, IAGE, and then she was elected as the chairperson of breast committee. And under her guidance, we had BreastCon in Indore. She has made vaginal surgeries very famous. She was a member of the executive member of vaginal surgery committee of MP, and then she has made vaginal surgery as part of all workshops all over India. She was joint secretary. She was secretary for AICOG, and under her guidance, Indore was so fortunate to conduct the AICOG. She conducts courses of vaginal surgery for ICOG and also for other academic courses. She is writing books. She has written many chapters in many books, and also now she is author of many books. And she has brought best out of us. Many of Indore members will say that whenever they are in a problem, Madam will rush for their help, be it a PPH or any other medical emergency or any surgical complication. One phone to Bapat Madam and she will run for our help. And she was vice president of Foxy. We were part of her campaign as vice president, and each and every member of Indore Society felt that it was their own fight. And now ma'am is running a presidential candidature, and we wish her best of luck. We all will join you for your campaign, and we'll do everything possible to see that you are future president of Foxy. I welcome you, ma'am. This series of Learn Simply is very useful for all new budding gynecologists and obstetricians. Just in a few minutes, we can learn so many things, small algorithms which help us in day-to-day our profession. Whenever we see a patient with similar problems, it flashes like, yes, this is what we learned in that class, and now this is the patient, this is how I need to treat her. Welcome you, ma'am, for this new series of breathlessness in pregnancy.
Thank you so much. Without wasting time, allow me to share my screen. And I'm sharing my screen. And today's topic is basically the acute shortness of breath. The problem, as we have discussed, that is learned simply in only in 30 minutes. So we have not reproducing the topic that we are going to have this topic or like that. It's a simple thing. So it's a 31-year-old, 34 weeks, presented to hospital, shortness of breath and the backache. She had a shortness of breath over the last 1 to 2 months, unimproved by the course of azithromycin. Upon arrival, she complained of the worsening of the shortness of the breath, inability to lie supine. During history, endorsed difficulty swallowing pills and a persistent dry cough. She had no interval improvement despite antibiotics and presumed upper respiratory infection. Her past medical history was remarkable. Vital signs included temperature normal, heart rate 109, blood pressure normal, respiratory rate normal, 96% oxygen saturation on the room air. Physical examination revealed a gravid uterus with respiratory distress, unable to lie supine, absent breath sounds in her left chest, and she had a palpable supraclavicular lymph nodes. Per abdomen, 32 weeks, soft, non-tender uterus, normal extremities, fetal heart racing in CTG normal, without contractions. Ultrasound revealed breech presentation, electrocardiogram confirmed only sinus tachycardia, but other imaging performed demonstrating a large heterogeneous anterior mediastinal mass with internal cystic changes versus necrosis and multiple enhancing left pleural nodules. Mass extended superiorly to the right paratracheal area and mass affect the trachea, right thyroid lobe, left mainstream bronchus and lung bronchi. A large left pleural effusion, near collapse of the left lung. Heart was shifted to right with a moderate pericardial effusion. Left main pulmonary artery was compressed by the mass, and there is no evidence of pulmonary embolism. Admitted for labor and delivery. So this type of case with acute shortness of the breath can come to us, and we should be able to differential diagnosis with other things also. Same with another 30 years patient in emergency department, shortness of breath, has a pulmonary embolism. Why we are saying pulmonary embolism? Dyspnea, pleuritic chest pain, hemoptysis, and maybe all the features of the history. Symptoms can be absent. Collapse, central chest pain indicate massive pulmonary embolism. Blood tests include arterial blood gas, classically shows respiratory alkalosis, but may be normal with small pulmonary embolisms. Treatment, if she comes right in a time and we are able to treat her, low molecular weight heparin administered immediately, and all pregnant patients with a suspected venous thrombosis, and until the diagnosis excluded, very, very important, anticoagulation is strongly contraindicated. And patient hypoxic tachycardia admitted for administration, observation should be followed regularly antenatal. I'm just putting these two scenarios. If some mass is there, and this is a case of, but now we are simply talking about how acute shortness of the breath comes, what are the risk factors, what are the differential diagnosis, how to treat, how to go for the algorithm and do it. Acute onset of shortness breath, dyspnea, pleuritic chest pain, cough, hemoptysis. It can come on examination, low-grade fever, tachypnea, tachycardia, diminished oxygen saturation, diminished breath sounds, audible crackles, and evidence of pleural effusion and pulmonary examination. Laboratory tests reveal acidosis, elevated A-A gradient on the ABG analysis. On AKG, evidence of right. I'm not talking, this discussion is not correlated with the previously two cases which I have talked about. So it's a general discussion when the patient of acute shortness of the breath comes to us. Evidence of right heart strain is a pattern with or without right XDC deviation and T-wave inversion. X-ray chest may be normal, show evidence of multiple peripheral wedge-shaped area of consolidation, pulmonary edema or pulmonary effusion. However, if ABG reveals arterial PO2 is more than 80, diagnosis of pulmonary embolism is highly unlikely. So we are talking about the differential diagnosis also. It's very, very important. Measurement of D-dimer level in pregnancy is generally unhelpful in making the diagnosis of pulmonary embolism. Okay, PE. Then how to differentiate? You have to differentiate many more things when the patient of the acute shortness of the breath comes. Pulmonary embolism, amniotic fluid embolism. She may be having pneumonia, including aspiration pneumonitis, Mendelssohn syndrome, pneumothorax, congestive cardiac failure, pericarditis, pulmonary edema. And sometimes venous air embolism, very rare, associated with the rupture uterus, placenta previa, and persistent arterial septal defect. So acute shortness of the breath, we have to differentiate between all those conditions. Eclampsia is also one of it. Drug overdose or a withdrawal is also reason. Sometimes a rib fracture, a patient come with a trauma or something, and she can have the acute shortness of the breath. Then amniotic fluid embolism is an obstetric emergency and 80 to 90% maternal and perinatal mortality. It accounts 10% of the maternal death also, and A is seen most common during labor and delivery and immediate postpartum period. Now, there are few risk factors when the patient comes with acute shortness of the breath. Is number one, cesarean delivery, if there is a chorioamnitis, multiparity, preeclampsia, prolonged labor, fetal demise, amniotomy, intrauterine pressure catheter, intrauterine saline injection in cases of abortions, placental abruption. So this list is basically, they give the risk factors for having the acute shortness of the breath, and we have to differentiate it right from pulmonary embolism to all the conditions. Now, how to characterized by normally acute onset of dyspnea, hypotension, hypoxia, and prodromal symptoms may include sudden chills, sweating, anxiety. These are the problems. Then physical examination may reveal acute onset of the respiratory distress. There may be a cyanosis, hypotension, tachycardia, hypoxemia, and neurological manifestations. Sometimes the seizures and the coma the patient can come with. And a hemorrhage. Hemorrhage is always, we should click in a mind. And DIC is usually acute and severe, leading to acute shortness of the breath. So acute shortness of the breath is maybe a presentation of any other conditions or any other thing. So whenever there is acute shortness of breath, we should be worried about. Then amniotic fluid embolism is a clinical diagnosis. X-ray chest versus scan is a little value in acute setting. Components of amniotic fluid, fetal spermas, and mucin may be identified in the medullary vasculature at postpartum, but this is not pathognomic, so it's no use to us. There is a primary supportive cardiovascular support should be optimized. This includes maintaining oxygen saturation more than 90% for any case of acute shortness of the breath. Then arterial PO2 must be more than 60 millimeters of mercury, and then systolic blood pressure more than 90, urine output more than 25, and ionotropic support, dopamine and a mechanical ventilation should be considered. If needed, then treat the bronchospasm, terbutaline, aminophylline, steroids as needed, and CPR and a cardiopulmonary bypass may be required if the patient is of acute shortness of the breath. DIC is a typically predominant clinical feature of amniotic fluid embolism, and serial CBC coagulation studies should be followed. Aggressive blood product replacement is initiated, and avoid heparin in established cases of DIC. So, and the fetus is at risk of hypoxic ischemic cerebral injury. IUFD can occur. Urgent delivery may be necessary regardless of the gestational age. Regional anesthesia is contraindicated in acute setting. General endotracheal anesthesia may be needed for cesarean. So, acute shortness of the breath. So, this is the algorithm when the patient comes to us. Take the concise focus history and perform a physical examination. CBC coagulation tests are there. ABG arterial blood gas and chest X-ray should be done. And we have to find out the oxygen saturation of that. If the patient is hemodynamically stable, if no, call a code, immediately anesthesia consultation, oxygen supplementation, place 2 large bore IVs, consider central hemodynamic monitoring, gestational latent fetal well-being, and treat likely the cause. Consider empiric anticoagulation if pulmonary embolism is suspected. So make it a point. If patient is hemodynamically not stable, think of pulmonary embolism, treat it. But if the patient is this hemodynamically stable, the initial state management, oxygen supplementation, gestational age and vital being we should find out. Place 2 large bore IVs, and we should do the serial IVG, EKG, X-ray chest. And subsequent management, consider the cardiology consultation. Then trans-esophageal echocardiography is also important to find out some big mass or anything is there. Antenatal steroids, if indicated, considers MFM and neonatology consideration also there. Further management depends on the diagnosis. See, we should be able to diagnose. If there is a pulmonary embolism and pulmonary edema, I will tell you what to do. If there is a pneumonia, supportive care, broad spectrum antibiotics, sputum culture to identify the organism, and narrow antibiotics, consider blood culture. Eclampsia is there. And if there is amniotic fluid embolism is in my diagnosis, supportive care, urgent anesthesia consultation, ionotropic support, consider early intubation and mechanical ventilation, aggressive management of, and consider urgent delivery once the mother is stable. Now I will talk about the pulmonary embolism and edema in this thing. If there is a pulmonary embolism, related pulmonary embolism, risk stratification, HD status, RB size, biomarkers, fetal status, then 3 tests are there. If it's high risk, intermediate risk, and the low risk. If it is high risk, cautious IV filling with adrenergic support, anticoagulation, IV, and then a hemodynamic and obstetric surveillance, and we need a multidisciplinary approach. If intermediate risk, anticoagulation with IV UFH, this are the low molecular weight heparin, short-term hemodynamic, and obstetrical surveillance. If low risk, still anticoagulation with low molecular weight hyperweight system. And if the patient goes on clinical deterioration, we have to worry about this. And if it's improving, still we'll continue the anticoagulation. Now, antepartum, IV thrombolysis at first, depending on the local expertise. Embolectomy or thrombolytic lysis, ECMO is also very, very important. Peripartum, high bleeding risk, consider ECMO, surgery, embolectomy, thrombectomy if available, or the thrombolysis with the preparation of major bleeding. Late postpartum, IV thrombolysis at first line, depending on local expertise, surgery, embolectomy, thromboblectomy, and ECMO is important. Now, this is for this, and if there is a pulmonary edema, activate the emergency response, call for help, skilled assistance. Number 1 is airway, clear the obstruction, upright position, administer oxygen. Breathing, assess respiratory rate, oxygen saturation, temperature, X-ray chest, arterial blood gas. Auscultate chest, consider non-invasive, invasive ventilation. If circulation, minimize aortocaval compression. Maternal, by BP, heart rate, rhythm and ECG and fluid balance. Fetal, heart rate and gestation. Intravenous assess, full blood examination. Assess renal function, assess liver functions, assess coagulation and cardiac enzyme. And transthoracic echocardiography, continuous monitoring. Hypertension, the treatment will be different and normal is the different. If there is hypertension, yes, we should control the hypertensive. Consider causes, administered drug, preeclampsia, endocrine disorder, illicit drug intravenous fluid and other, and administered nitroglycerin, furosemide, morphine, magnesium sulfate, calcium antagonist. If she is a normotensive, consider cardiac diseases, sepsis, tocolysis, amniotic fluid embolism, aspiration, IV fluids and other. Drugs to be administered, furosemide, vasodilator, inotropic support and mechanical support. And both are there that stabilize pain, save birth and transfer to the intensive care environment. So thank you so much for the patient listening and thank you so much for being with me today.